All right, so as we've talked about, the Family First Prevention and Services Act is the most significant and transformational piece of federal child welfare legislation since the Adoption and Safe Families Act of 1997. You hear that a lot, but it is real. It is dramatically altering the financing structure of federal child welfare programming. Now, that can be a really wonky conversation, but I'll just try to demystify it a little bit. There are a number of federal funding sources that contribute to child welfare programming. The lion's share of federal child welfare funds comes from Title IV-E of the Social Security Act. That is where the majority, where billions of child welfare dollars are invested from the federal government. Now, historically, up until Family First, the Title IV-E funding could only be used for children after they come into foster care, and not even for services, for foster care maintenance payments, for administrative costs associated with caring for those kids, some other elements like training and IT. But just think about that the vast majority of federal funds were invested after a child and family suffered the irreparable grief and trauma of a child removal, and that we weren't investing those resources earlier to prevent that from ever happening. For the first time ever, Family First is shifting that on its head and making some of those federal 4E funds available for preventive services. That is a big, big deal. Title IV is also an open-ended entitlement program, meaning it's not a grant, it's not a formula like some of the other opportunities, but it's based on eligibility. So there aren't those limitations that are placed on it like there are some other funding resources. So that's a really big deal. And it provides the opportunity for states to reorient their systems, likely where they should have been from the beginning around prevention. The restrictions around congregate care that we'll talk about in greater detail provide the opportunity to really focus on increasing the number of kids that are placed with families, because kids do best when they're placed with families, and to right-size congregate care. And by that I mean that we're only using residential and group treatment for kids that have a clinical need to be there, and not just because we can't find a bed for those kids, and that we are going to be using that appropriately to meet the clinical needs of these kids and families. So now it's time for a really brief history lesson, and I promise it's the abridged version. And I'm going to steal Commissioner Clark's line that we really can't see where we're going if we don't see where we've been. So I'm just going to kind of walk through some of the major pivotal moments of federal child welfare legislation over the last 40 years or so. The first piece is CAPTA, the Child Abuse Prevention and Treatment Act in 1974. Anybody ever heard of it? CAPTA? Not part of your normal dinner time conversations? CAPTA was the first piece of legislation that established that almost created the child welfare system as we know it. That's where the first mandatory reporting laws, or child abuse and neglect reporting laws were first introduced, where the notion of mandatory reporting was introduced. That's when states started developing hotlines. And from there, that was really the foundation of creating the system that we're most familiar with. However, states were not prepared for the volume of calls that they were going to start receiving once this became a thing, and we quickly saw foster care caseloads begin to rise. The next big piece of legislation was the Adoption Assistance and Child Welfare Act of 1980. Anybody ever heard of that? No? Great. That was the first time that we started talking about reasonable efforts to prevent removal, reasonable efforts to reunify. That whole notion came about from that piece of legislation. That's where the whole issue around permanency planning was first institutionalized in court reviews for cases. That was the foundation for that. Then over the next 20 years, we saw child welfare caseloads rise dramatically, the crack cocaine epidemics and other issues that states were facing with. Quickly, we reached a position where foster care caseloads were at epic proportion, where we had well over 500,000 children in foster care. And people started to realize we need to do something about that. And that's when the Adoption and Safe Families Act was passed in 1997. And from there was the increased emphasis around permanency, around promoting adoption as a permanency option, around shortening time frames. And it was an effort to get pretty aggressive on trying to reduce the number of kids in care and try to get kids out to appropriate permanency, with specifically taking a look at adoption. That was probably the most recent piece of legislation of the magnitude of the Family First Act. Now, over the 20 years or so that followed, it was recognized throughout the field that the way that the funding structure was set up was not right for kids and families, was not necessarily going to achieve the best outcomes. And so there was this notion of Title IV waiver authority, which was used periodically throughout time. And that sounds kind of wonky, but really all the waivers were an opportunity to give states the chance to break the funding rules, try to spend the money in a different way, implement and test new innovations, and see if we got better results for kids and families. And there's waiver authorities been open and closed periodically over the last few decades. But in 2011, Congress granted the Department of Health and Human Services unprecedented authority to grant Title IV waivers. And the Federal Department of Health and Human Services, the Children's Bureau, were able to grant up to 10 new Title IV waivers in each of federal fiscal years 2012, 13, and 14. Now, why do we care about that? Because we have been operating in the state of increased innovation in child welfare over the last 5-6 years or so, where all states were recognizing we need to do something different. We need to figure out how we could reduce the flow of kids coming into care, how we could get kids that were in care home to permanent families or were unified with their families as soon as possible, and that we needed to be stepping kids down so that they were in a level of placement that was commensurate with their needs. And we have seen 20 plus states implementing and testing new interventions over the last 5 years, of which Kentucky has been at the front of the pack, recognizing the substance use issues that many of your families are dealing with, looking to implement and test START and K-STEP, where Kentucky's been right at the front of the pack over these last 5 years, thinking about new ways that we could serve families. And this whole spirit and culture of innovation, the need to do something different, was really what provided the foundation and ushered in the Family First Prevention and Services Act in 2018. Because Congress, listening to state leaders, listening to advocates, listening to kids and families say we got to do something different, and they responded to the call with the passage of Family First. So there's your history lesson. You can all get credit for that. Everyone gets an A. While the legislation itself is really complicated, it's really long, there's a gajillion provisions, we are going to focus on the most transformational dimensions of Family First, which is really the prevention and congregate care provisions. This whole notion of now being able to tap into Title IV funds to provide prevention services before a family destabilizes to the point that a removal into foster care is necessary is monumental. And it is now giving us the opportunity to redesign and restructure our system, likely how we should have probably been doing it from the very beginning, to try to invest more resources on that front end and not so many resources on the back end. As Commissioner Clark said earlier, and Jessica and others that have mentioned this, as of October 1, 2019, or the beginning of federal fiscal year 2020, so now we're about, I can't do math, like 9 months away from that date, give or take, will be the first time when these Title IV funds are going to be available for preventive services. Now, it's important to note that it's not prevention services writ large. It's prevention services that are focused in 3 specific categories. 1, in-home parent skill building and capacity building. 2, mental health treatment. And 3, substance use prevention and treatment. So the prevention services that we're talking about need to fall into one of those 3 categories. Fortunately, it speaks to a lot of the challenges that families are dealing with, but it is important to clarify that it's not preventive services writ large. And each of the preventive services that states will put forward in their prevention plans must also be administered from a trauma-responsive framework or a trauma-informed framework, both in terms of organizational culture and our structure and the treatment model. So that's just an important theme to pick up because it's going to come back again in the congregate care conversation, that's one of the underlying themes of Family First, is this notion of how can we create systems across the continuum of care that are more trauma-informed and trauma-responsive, where we understand the impact of trauma on kids and families, both their trauma histories as well as the additional trauma that we inflict on families by even getting involved in removing children, and then responding in a way that's much more, that recognizes this trauma, that responds appropriately, and that we're actually going to be investing in services that have this trauma-responsive framework as well. Also, here's the other big catch, and it is a catch. These preventive services must be evidence-based. That sounds great. it is great. We want to be investing our resources in programs and interventions that we know work and that are likely to improve the outcomes for the kids and families that we're serving. So that is absolutely a step in the right direction of what we want to be doing. Some of the challenges are there. It's really hard to implement EBPs, and we've learned that through the waiver dialogue through years, that actually identifying the right EBPs, implementing them, scaling them up to the point that they're available and that there's slots available for all families that need them, getting families to the treatment, completing their course of treatment. There's a whole host of challenges there, and I don't want to minimize that as we have this conversation. Yes, awesome, 4E's available for prevention. Yes, awesome, we want to be investing in more evidence-based practices, but that's going to be a real call to arms for everybody in the child welfare community to think through what are the right interventions, how are we going to scale them up, how are we going to build the capacity of our service providers, how are we going to be building the capacity and resources of our caseworkers to identify what are the right services that families need, be able to actually get them there and to support their involvement in the treatment. So these are all things that we want to be thinking about in terms of what it's going to take to actually achieve this transformation. It's not just making the money available, that's the first step, but there's a tremendous amount of system reform that needs to happen to support Kentucky's ability to take advantage of these opportunities. The preventive services that are going to be available will also be notified by the Federal Children's Bureau which ones are going to make it on the list and what level of evidence that are going to be associated. Many of you guys might be familiar with existing evidence-based clearinghouses, perhaps the California Evidence-Based Clearinghouse, NREP, SAMHSA has got one. There's other resources out there which will give you a good idea of the options that are out there and the level of evidence that's behind them. The law mandated that HHS establish its own clearinghouse. So they contracted with APT. They have a whole group now that's working to review the evidence that exists in the field, and they'll be letting us know what are the services that are going to be allowable and what is the level of evidence behind them. And so that'll be something we'll be eagerly awaiting additional guidance on as we move into 2019. Big things to note. There is no income test associated with the preventive provisions. Remember a few minutes ago when I was talking about how the federal financing was structured with the majority of money available only once kids come into care? Well, that conversation is even more complicated because it's not all kids that come into care. It's kids that meet Title IV eligibility criteria, of which there's a range of eligibility requirements, one of which is the requirement that the home of removal meet the poverty guidelines of the state from their AFDC plan in 1996. Think about that for a second and how antiquated that is. That we are not only expecting families that come into care to get those federal resources available for reimbursement, they need to meet certain poverty guidelines, but it's also the guidelines from 1996 because the way the law is written goes back to then. So what you can imagine, every year that we get away from 1996, the fewer and fewer kids and families meet that Title IV eligibility criteria, right? Because we have families that are really struggling, but not struggling by 1996 standards. So not only is the funding structure something that we really want to question, but also we have fewer and fewer families that are meeting that criteria as further away that we get back from it. Now, that doesn't change under Family First for kids that come into care. So unfortunately, those set of rules are still in effect. But to access the prevention funds, the AFDC test, the eligibility test, does not apply. So that's not there. So that is a major reversal and one that we want to pay attention to, and it's a big deal that we're not dealing with those same kind of requirements. Preventive services can be funded for up to 12 months at a time. However, CB has clarified, the Children's Bureau, sorry, I spent over 10 years there, and so I sometimes fall into alphabet soup. The Children's Bureau has clarified that families can receive additional 12-month cycles. There just needs to be a redetermination that the child is a candidate for foster care, that these services make sense. So they can be funded up to 12 months at a time, but they can be renewed for an additional 12 months, and those can be contiguous. And at least 50% of the services that states are going to put forward, or that Kentucky might want to put forward in its preventive plan, need to meet that well-supported guideline. So we talked about promising, supported, and well-supported. Half of the money that the feds will reimburse needs to be for services that meet that well-supported threshold. And it's important to know that there's not a whole lot of programs out there that meet that well-supported threshold. So that's this other theme that we want to be thinking about, that this law as it stands is not enough, And we need to be continuing to grow the evidence base around child welfare, to continue to invest in evaluations and other research to help build evidence so that we can get more interventions up that evidence chain into that well-supported category so that we have more options for kids and families. And what I would encourage Kentucky to do is the same thing I say to a lot of states. If there are programs that you know work for Kentucky's families, but maybe don't meet that level of evidence yet, think about opportunities to invest in some evaluations or other opportunities to try to move them up the evidence chain so that it becomes more of an option for more kids and families. So what are the major opportunities that we're talking about around prevention? Is that we have this opportunity now to transform our system so that we're focused more on prevention, more on promoting and preserving family stability and well-being, and less focused on removing kids from care and then trying to figure out what we're going to do after that. Investing in evidence-based interventions, that's a lot of what I just talked about. It also goes back to the case practice elements there too. It's not only investing in EBPs, but thinking about how to scale them up, how to do quality assessments of kids and families so we know what the right interventions are, and then be able to get them to them. It's not just opening the floodgates and making it possible, but really making sure that families are getting there and that it's the right set of services that are going to meet their needs. Increasing that lens of trauma responsiveness across the continuum of care, and then being really clear from the beginning that this is not something that child welfare can do on its own, but this is an opportunity to really partner across systems. It's child welfare, it's juvenile justice, it's mental health, substance abuse, health, our partners at Medicaid, that if we're going to build a continuum of care that's more heavily invested in prevention, it's not something that we can do alone, but something that we're going to want to get around the table with our partners and carve out what everybody's individual roles are in building the system of care that's really going to work for kids and families. So going to the complete opposite end of the child welfare continuum, the other big conversation, the other big provisions within Family First relate to right-sizing congregate care. Meaning, how do we get, so we're using residential treatment, institutions, group homes, really treatment facilities, only for kids that have a clinical need to be there, and not because we just haven't been able to create an array of placement resources that really is the best fit for kids. This has been a growing conversation over time. We know this. We know that kids do best in families, preferably their own. We know that kids that are in residential care experience disproportionately bad outcomes in terms of educational attainment, economic attainment, housing stability, and other outcomes, and we want to do something that we're only using those resources so when they're time limited and to meet clinical needs of kids and families. And what the feds have done is said, we're not going to pay for it anymore. We are not going to pay for residential treatment for kids that don't need to be there, and they're applying some significant restrictions, where they're only going to provide the maintenance payments, like the reimbursement costs for kids that are placed in facilities that meet the qualified residential treatment program criteria. And I'll say a bit more about that in a couple of minutes and what actually goes in there. They're not going to pay beyond a stay of 2 weeks unless the facility meets the QRTP criteria, and unless that child has an assessment that says that that is the appropriate place for the child, and that assessment must be completed within 30 days of the child going to the residential treatment facility. So the facility itself needs to meet the criteria, and the child needs to meet the clinical needs to be there. If that happens, then that federal reimbursement is available, same as it always been. If it's not a QRTP criteria and that child doesn't have a clinical assessment that says that they're supposed to be there, then that federal reimbursement for maintenance is going to stop after 2 weeks. There's a couple of additional caveats that in the wisdom of Congress they were able to think through. So that in addition to that, states must also have a protocol or a plan in place to prevent inappropriate increases to the juvenile justice population. So, okay, we got these criteria. We can't just take kids and shift them over to the JJ track because we've got these child welfare restrictions. It doesn't seem from everything that I've heard that that's really going to be an issue here in Kentucky, and you guys are doing great practice there. But it is important to note that that is one of the caveats within the legislation. Secondly, there must be protocols in place to prevent inappropriate clinical diagnoses of kids, just to make this. So what that means is we can't give a kid a diagnosis to make it okay for them to be in a residential treatment just to try to get around this. And so we're going to be thinking very carefully about our assessment processes, how that's going to work, how diagnoses are being assigned to make sure that, again, we are only using residential treatment for kids that have the clinical need to be there. Now, Commissioner Clark mentioned that this morning there are some time frames that are associated with this. So while Family First was passed in February of 2018, states have the ability to delay the effective date of these congregate care provisions for up to 2 years. They don't have to, but if they want to, they can delay these congregate care restrictions up to October 1st of 2021. However, if a state chooses to delay congregate care, or delay the application of these congregate care restrictions, they cannot take advantage of the new funding that's available for prevention. These things are tied together. So there's a bit of you want to make this benefit available on the preventive side, then we need to be applying these congregate care restrictions. And so Kentucky has been leading the charge, saying that we want to go first. We can implement as of October 1, and I think you guys are well positioned to be at the front of the pack in both implementing these congregate care restrictions as of October 1, but then also opening up the opportunity to take advantage of these preventive provisions. Does that make sense? I saw like 6 people nod, so I think that's enough for me to go on. So what is a QRTP? Everybody that likes acronyms, get to know this one. It's a new one. Not to be confused with the PRTF, which is another acronym here in Kentucky, but the Qualified Residential Treatment Program are programs that are licensed and accredited, that have a trauma-informed treatment model and organizational structure. So there's that theme carrying over from the preventive side. That facilitate outreach to and participation of family members in treatment planning and service provision. This is, I think, one of the biggest catches that we're going to see, really working with our providers to create models where we're more inclusive of families, both in the assessment and the planning processes, but then also the treatment provision, and there needs to be mechanisms for doing that. Also, there needs to be, this is not on the slide, but processes for providing post-discharge support and in-home support for kids once they leave the residential treatment facility. And a QRTP must have their nursing or other licensed clinical staff on site in accordance with the treatment model, and I'll come back to that for a second, and accessible 24/7. This seems to be one of the provisions that gets people a little antsy. It's not that there needs to be clinical staff on site 24/7. That's not what the law says. Is that they need to be on site in accordance with the treatment model that's being used at the site. So whatever your model says you're supposed to do, that's what you have to have in terms of on-site availability, and then just accessibility to these clinicians 24/7 to help meet the needs of kids. So some exceptions to this. Okay, I can't. Can you people see? I can't even see over there to know if I'm on the right slide. I think I am. So some exceptions to these QRTP requirements are for facilities that serve pregnant and parenting youth. These restrictions and criteria don't apply. Supervised independent living resources for kids that are aging out of care, transitioning out of care, doesn't apply to them either. Nor does it apply to specialized placements for youth that are victims or identified as being at risk of trafficking. So it doesn't apply to those kids either. And nor does it apply to residential family-based substance use disorder facilities, because that's actually another really great benefit of Family First that's in place right now, is that the feds will reimburse maintenance payments for children that are placed with their parents that are in residential substance use treatment. So that's awesome. That is a new opportunity. The issue is, we don't got enough residential substance use treatment that will have their kids be able to be placed with their parents. So that's another opportunity we want to think through and try to make more of that available. But there are some additional federal resources available there as well. So what does this mean in terms of opportunities here? Well, we can right-size Kentucky's use of congregate care to only kids that have a clinical need to be there. That is a game changer for Kentucky, and it's a game changer for every kid that's currently in an institution that has no business being there. It's an opportunity to build an array of placements that's best suited to the needs of kids and families, so that we are creating placements that respond to the needs of our kids. We're not placing kids in the placements that we happen to have. That is a major shift that we want to work toward, and this is an opportunity to create that array of placement resources that's going to be the best fit for the kids that we're serving. And I think an opportunity to really, going back to some of the kinship conversations that we had before, really think about how we can leverage relatives. I think relative care is a linchpin in this entire Family First conversation. In congregate care, I think if we do a better job of family finding and identifying and supporting relatives, they could be that placement option that's not the institution. On the preventive side, I didn't say this explicitly, but I'll say it now, we can also use kin as temporary resources to place kids not officially in foster care. Placement and care responsibility would not be taken by the state of Kentucky, but we could identify relatives that could temporarily take care of their kids while we get their parents into those evidence-based treatment resources. So I think if we really want to think about the great work that's happening underway to reform Kentucky's use of relatives, and I think that's going to be a great opportunity to focus on, to take advantage of everything across the Family First legislation. We talked about preventing the inappropriate increases to JJ populations or inappropriate clinical diagnoses, and it's a really great time to think about expanding the business models of our provider community. From my understanding of Kentucky, capacity is a huge issue. We've been experiencing these unprecedented rise of kids in care. We don't have enough providers, at least to take care of the kids that we have. This is an opportunity to think about how do we expand business models. If we're normally a brick and mortar institution, how do we think about expanding models to focus on doing more treatment foster care or figuring out how to provide those clinical interventions in community-based or family settings? This is an opportunity to really think differently about how we've done the work and to create a system that works best for those that we're trying to serve. And I think that's a really tremendous opportunity and one that's frankly going to have to be taken advantage of if we're going to be complying with these new congregate care restrictions. Just a couple of other things to say. There are some additional Title IV dollars now available for evidence-based kinship navigator resources. So there's some additional money there available to support these relatives that we're talking about. There's also an expansion in the ability to use Title IV-B funds. So Title IV-B is another major federal funding stream. The pros of it are that it's incredibly flexible. The cons of it is that it's not a very big funding stream. So there's no new money here, but there is an expansion in the law that allows for Title IV-B funds to provide up to 15 months of post-reunification services. So that's a door that wasn't as open before, so there's another opportunity. The Chapin program that serves transitioning youth can allow services for kids that have aged out or adults that have aged out up to age 23, and it expands the use of the education and training vouchers up to age 26 for 5 total years of eligibility. So the catch there's no new money in Title IV-B or Chapin or the ETV program, but there are expansions in who we can use them for a greater amount of time. So I want to take this conversation back to where Commissioner Clark was earlier and the 3 priority outcomes that are driving Kentucky's child welfare transformation. Safely reducing the number of children that are entering care, improving timeliness to appropriate permanency, and reducing caseloads. All of that is in perfect alignment with the ideological, philosophical, and practical underpinnings of Family First. Kentucky's transformation is in lockstep with this federal legislation, and that's just bringing all of these different forces together that I think are really creating the opportunity for real, meaningful, and sustainable change. And Family First is just one lever. It's not about complying with Family First or responding to Family First, but really leveraging Family First to further the transformation that you guys already have underway. It's not the tail wagging the dog. You guys are in charge. The transformation is underway. And Family First is just one opportunity that you can leverage to further the transformation that you're already undertaking. And it's not about Family First. It's not about what it is. It's about what it means. And what Family First means is that Congress and the national child welfare community and state child welfare leaders have recognized that the system we built does not work. It does not effectively serve the kids and families that it's meant to, and that we need to do some radical change to do better and to do right by our most vulnerable kids and families, and this is an opportunity to do that. So I am so proud to be able to walk alongside Kentucky on this journey and continue to work with you guys on a number of these reform initiatives, and hopefully this answers and demystifies a bit of the questions and some of the elements of Family First. And if anybody needs me, there's my contact information. You can call anytime. Well, not even within business hours, whenever you want. It's fine. So thank you.